Hey guys, my name's Sam from the Queensland Ambulance Service. Just going to go through anaesthesia planning and RSI and also some capnography as well. So first up, why do we do RSI? So I guess neuroprotection for head injury patients, anticipated clinical course requiring anaesthetic and airway ventilation compromising for humanitarian reasons as well. So at the moment we've got an unconscious patient, currently has nasal prongs at high flow oxygen on at the moment, currently has a oropharyngeal airway as well. Patient's being now pre-oxygenated at the moment, so we've got two oxygen sources, one for the nasal prongs and one for the bag valve mask as well, pretty important. While we're doing this, we're assigning roles as well, making sure everyone knows what they're doing. One person would be great if they could be pushing drugs, monitoring the patient and also any fluids as well. Another person can be the airway assistant. So at the moment, it'd be great if we had a checklist as well. For me, I go through a little bit of an acronym called SOAP-ME. So S suction, O for oxygen, A for airways, P for positioning, which we've got at the moment, monitoring meds, and N tidal, and any other equipment that we need. So first up, pre-oxygenation. So we've got a bag valve mask. We can have some PEEP if we want to as well. N tidal is connected to our monitor. At the moment we've got a life pack 15, and we've got an OPA at the moment with nasal prongs. So two, assessment. We want to make sure that the patient's been assessed with their BGL, ECG's done, normal blood pressure, N tidal and SpO2's connected as well. So just get all the basics out of the way before we actually do this. We've got access. So at the moment we should have two kind of large bore cannula accesses if we need it. So at the moment we've got one connected up to fluids and another one if we need to push any further drugs through the other line. And if one does dislodge as well. And if we can't get that, we can also go for IO as well. At the moment, fluids are free running, and also we've got suction under the pillow, ready to go, just in case. Now, our equipment that we need, so heading over to our airway stuff. So over here we've got two laryngoscopes, one just in case the light doesn't work, and size 4 on that. We've got our bougie over here, and we've got two in ETTs. One should be slightly smaller, so a size 8 and a size 7, or if your service does half sizes, even better. Unfortunately, I've only just got two size 7s. That's all I could find in the expired stock, and should be a 10mm syringe. Doesn't have to be connected, but cuffs checked as well. We've got a stylet just in case we need it, McGill's forceps. We've also got a LMA just in case for an emergency if we have a failed intubation. We've also got a manometer on the side here to check our cuff pressure afterwards, and also a Thomas tube holder. And hopefully our airway assistant is competent in doing the railroading of the procedure. Now once we've understood what kind of airway stuff that we're using, we can move over to positioning of the patient. Now we've already done a video demonstration on positioning, just making sure the head's up a little bit if they're quite obese, ramping underneath their body, just aligning those axes, just to make sure you're doing really good forward planning of this. So at this stage, we're still pre-oxygenated the patient with those nasal prongs at high flow and also a bag valve mask as well. We're heading over to now drugs. So ambulance service, we can use ketamine and fentanyl as an induction agent. With fentanyl, we give one-off dose of 25 mites. It's not actually a weight-based dose, but usually it's 1 to 2 mites per kg. However, ketamine, it's a bit of a whack that we can give them. So 1 to 2 milligrams per kg. So this patient is 70 kgs, we can give 140 milligrams as an induction agent. It's really good ketamine, I guess. You can give, can be for sedative effects, pain relief, hypnotic. So it's really good all-round drug for RSI. And for our paralytic agent, we can give rocuronium. So rocuronium is at 1.2 milligrams per kg, 70 kg patient, 84 milligrams total dose. So if our airway person's ready, we've assigned our roles, we've got someone pushing drugs. If not, I can push drugs myself. And we've given that paralytic agent. Once that patient's respiratory drive starts to drop off, we can still ventilate them a bit more, and then we can perform the procedure of laryngoscopy with an ET. So I'll do that now. So of course I've got my appropriate PPE on as well, with my gloves and glasses. So pre-oxygenated patient, laryngoscope into the right hand side, sweep the tongue to the left, visualising those vocal cords, visualising the whole time, and getting my airway assistant to come over, give me that bougie. I've got this one pre-loaded with an ET on, just because it's a bit easier for me, since I haven't got an airway assistant. Visualising those vocal cords, bougie in, and then I can railroad that tube on by myself. Okay, onto the, just can see the second mark now, and 22 at the lips. Great. Laryngoscope out, bougie out, and I'll get my airway assistant to hold my ET tube in. Need to confirm placement as well. Alright, so confirming placement as well. Alright, so confirming placement, I really want to see equal rise and fall of the chest. I'll auscultate the chest, auscultate the abdomen region just to make sure it's actually in the lungs. Fogging and misting of the tube, and also gold standard end-tidal CO2 capnography is coming back on my monitor here. So I'll give it a few breaths just to make sure that end-tidal is really, really good. And funnily enough, it's really good seal. I haven't even inflated any air in yet. I'll inflate some air now, 10 mils, and I can confirm how much after. So it's really hard without an airway assistant. Cool. Done. And that's in there. Awesome. Now I can tie off my tube. I've got a Thomas tube holder pre-loaded on here already, so it's a lot easier for me to do. And I've pre-oxygenated the patient, so I can do this, tie it up, and once that's on, you can also have a bite block as well. It's a bit hard with a Thomas tube holder to use a bite block with an OP8 airway. But we'll just confirm, auscultated the chest, fogging, missing of the tube, end-tidal capnography. And then we can do some post-cares as well after that. Done. Now moving on to end-tidal CO2 or waveform capnography as we see it on the monitor over here. So it's the measure of exhaled carbon dioxide from the patient, and it's in the very end of the exhalation phase. So that's the number that we see in millimetres of mercury. Normal levels 35 to 45, yes, there's some cellular metabolism going on. What it could mean if there's a sudden rise in end-tidal CO2, the patient may have ROSC if the patient's been in arrest. But however, it is the gold standard post-ET placement. You're really looking for those really good waveforms when you are ventilating the patient. Sometimes if you do put the ET tube into the gastric contents, you may get a bit of a positive reading at the start, but after a few breaths it will taper off to pretty much to zero. There are some false negatives to this as well. If the patient's just has a carbonated drink, that will increase the CO2 levels in the gastric contents quite significantly, but after a few breaths it will definitely taper off. But that's just something to take into consideration, I guess. So that's about it.